Irving, thank you for coming here today. I wanted to take advantage of your presence to just have a little bit of a question and answer informal to go over some of the things that you often talk about in your lecture. So we already know at this point, having read some of the papers that you've written, that antidepressants are probably not as good as we once thought they were. We were told they were. And now you're coming in and you're saying not only that they're not as good as we were once told they were, but they also come at a cost, at a financial cost, at a side effect cost, and maybe even at a withdrawal cost when you try to get off them. So it's no longer a question of, oh, try it, it's just like you try a placebo, see if it works for you, it doesn't work for you. There are some costs.
Yes.
Some of them hidden, some of them not so hidden. The first question that I have about this is what you know and what you are communicating to the public, how widespread is it in your opinion? How many people know about this? Is this something that only the psychiatry community knows? Is this something that the general psychology community knows? Is this something that a lot of people know? What is the state of knowledge of this particular kind of research?
Okay. It's not very well known among the lay population, certainly. Among the people who take these medications, people who suffer from depression, usually don't have this information. The psychiatrists, by and large, know about it, but are very resistant to it. But it's become a big stir. There's been a big stir about it, and in psychiatry it's become a big controversy. So they know. They're not inclined to accept it. But I think awareness of it is growing, and I see many signs of that in terms of communications that I get from psychiatrists.
Are we close to reaching a critical mass of people who are in the know that would transform, change, or otherwise revolutionize the landscape so that people will be less on antidepressants and more on other options?
I wouldn't say that we're close to that. It's certainly begun, but it takes a long time for something like that to change. There can be a lot of resistance, especially when you have people who don't have alternatives. Now, psychiatrists, back when I was a practicing psychologist, psychiatrists also did psychotherapy, but that's relatively rare now. Many do not, and those who don't, what else do they have to offer someone who is depressed with the medication? And that very naturally would make them resistant to being able to accept this information.
If I had to distill the major recommendations from your talk and from the body of evidence that you're putting forward, is you're basically saying antidepressants should not be the first go-to option, but you should also not do nothing, because when you do nothing, things don't get better. You're saying if you're already on an antidepressant and it seems to be working, it's up to you if you want to continue or not. If it's working for you, why not stick with it? But if it's not working for you, taper off gradually, make sure that you do it responsibly, and you don't get yourself into some kind of trouble with withdrawal and with relapse and things like that. What other options are there for people who are diagnosed with depression, feel depressed, and are not going the antidepressant route?
Yeah. So first of all, if you're going to withdraw from it, you should do that, I think, with the guidance of your prescriber. You should talk to the person who's prescribing it, your concerns, your intent, and with help in tapering off. And that is very important. But there are lots of other alternatives, and they include psychotherapy, of course, the best known, the best studied of the alternatives. There are others alternatives that have been studied to a lesser degree and seem to produce the same benefits that you get on antidepressants and with psychotherapy. And these include things like physical exercise, which is good for your health in a lot of different ways, not just for dealing with depression, but also things like yoga and meditation and Even homeopathy has been shown to have the same basic effects as antidepressants, and that to me would suggest the placebo effect as well, given that many homeopathic medications are given in doses where there's not even one molecule of the...
Yeah, and homeopathy really goes against the fabric of chemistry and physics in the sense that, you know, we really know that in certain dilutions there's really no shred of any molecule in there. And then we know that whatever you're taking is completely or almost entirely based on what you're expecting, what you're thinking, what you're believing.
And yet it winds up in clinical trials to seem to have give the same degree of antidepressant benefit as getting an antidepressant or doing any of a number of other things. The nice thing about these various alternatives is that they don't have the dangers and the risks that are and the side effects that are associated with the antidepressant use.
And when you mention psychotherapy, is there a particular psychotherapy that is more preferred? So we know about CBT, cognitive behavioral therapy. There's also interpersonal therapy. There's a whole bunch of them. Is there a particular kind of psychotherapy that has been studied more than others?
Well, CBT has been studied more than others, and especially Beck's cognitive therapy for depression. That has been studied more. On the other hand, data comparing one psychotherapy to another in general, not just for depression, generally does not find a lot of differences between, especially if whatever people believe in, whatever the therapist believes in, if you have a good therapeutic relationship and both parties believe in this approach, you tend to get very good effects.
Mm-hmm. Mm-hmm. In terms of other options to psychotherapy, you mentioned meditation and yoga, you mentioned physical exercise, you mentioned even, you didn't mention, but we can talk about, walking in nature, spending more time outdoors, and so on and so forth. At the end of the day, whether it's homeopathy or qigong or whatever it is, we are hearing just from, the transcendent vibrations of what you're saying, that it's in the mind of the beholder almost. It's something about, maybe social support networks and things of that nature are good alternatives to antidepressants.
Yeah, they do seem to be good alternatives, and indeed the eye of the beholder can be very, very important. That's the basis for what we call the placebo effect, is the person's beliefs and expectations about what this treatment is going to do to them. And we know from considerable research in all kinds of areas that the placebo effect is real and that it can make a difference.
So when we're talking about the placebo effect, I find myself many times speaking to colleagues, and I find in the conversations that I have with them a lot of misconceptions on their part on what placebo effects are, how frequent they are, how ubiquitous they are, and how big the side effects are. One of the things that I wanted you to clarify a little bit is, what's the difference between, let's say, conditioning and placebo effect? So a lot of people say placebo effects are just, you're just conditioned to respond a certain way when you get it. And you have a very refined conceptualization of how placebo effects are different from just Pavlovian conditioning, for example. Can you expound on that a little bit?
Sure. What placebos do is they play off of expectations. The placebo triggers a belief and expectation. Now, the acquisition of those expectations can come from many different sources. Classical conditioning is one way of learning to anticipate a particular outcome in response to a particular stimulus. Verbal information can do the same thing. Whether verbal information alone is better than verbal information plus conditioning, or conditioning alone, that's an empirical question that we'll see. There have been some studies of that. There needs to be more studies of that. But it's not just an automatic process. It does appear to be cognitively mediated, especially mediated by what the person believes is going to happen, what they think is going to happen.
Would you say that some people are more placebo prone than other people?
As a general rule, no. For a particular kind of placebo, yes. So if you ask someone who believes in acupuncture, they will expect a greater response, reaction to acupuncture than someone who doesn't believe in it, and they are likely to get the better response from even from sham acupuncture, because there's such a thing called placebo acupuncture.
Right.
On the other hand, the person who benefits a lot from sham acupuncture is not the same person who might benefit from a placebo pill. Depends on the culture they're in and the culturally induced and otherwise induced beliefs that they have.
Mm-hmm. In general, would you say that placebo responsiveness fluctuates quite a bit as a function of time? So somebody who's responsive to or is able to generate a placebo effect today would not be able to be as responsive tomorrow or next week or next month, even within the same domain, or is it a stable thing?
Within the same domain and the same placebo, there is a lot of consistency. So we get very high correlations when we give the same placebo at one time and give the same placebo 2 weeks later, which we've done in one study. We did that, and for some of the people, we changed the name of the placebo. When we changed the name of the placebo, when they think they're taking a different drug, the correlation vanished.
Mm-hmm.
Became close to zero. So placebo effects are reliable over time if there's the same beliefs, if it's the same placebo. The person says, I took that drug before, it worked wonders for me, so they have high expectation for that drug. Oh, this is a drug I've never tried, I'm not as sure of what to expect. And a related myth is that placebo effects are short-lived, and they're not. They last. With some conditions like depression, they increase rather than decrease over time, and I've seen studies where the placebo response winds up lasting as long as the drug response, up to 2 years, for example, in one study I can think of.
How do you explain this to people who have a very clear thinking about placebos as being very short-lived, very temporary, and also very weak? How do you demonstrate to them that that's not the case?
Well, with people who are professionals, people in the field, I point to the data, to the evidence. We do have clinical trials. We know from the data that we can get some very strong responses with placebos that you can't get without, if you don't give anything, not even the placebo. We know that they can be very powerful responses depending on the condition and depending on the nature of the placebo and how it matches that condition, and that then the response, once you get it, can last for a long time, especially if you keep getting it. It's just the same way with the active drug.
The whole discussion that we're having about placebos and things like that leads me to a slightly different topic but related, and that's the topic of suggestibility. Another topic that you are well known for, and you've spent a long time thinking about, writing about, and contributing to the literature. Do you think that there's a relationship between how suggestible a person is and how susceptible to placebo a person is?
Okay, so with that, again, there doesn't seem to be a broad trait of suggestibility that goes over a lot of domains. So you can be more or less suggestible to this placebo or to that placebo. That's not related to how suggestible you are in terms of hypnotic suggestibility, for example, which in turn is not related, neither of them are related to what's called interrogative suggestibility, the tendency to develop false memories when they're being suggested to you that, oh, this may have happened, just think about it, imagine it, not using hypnosis, not using placebo, another form of suggestibility. Each of those has its own reliability, but they are not correlated.
Is hypnotic suggestibility, or hypnotizability as you like to call it, is it different from other forms of suggestibility?
Yes. It's
Can
different.
can you explain to somebody who doesn't know too much about hypnosis, can you explain what the difference would be?
That's a good question. Well, the first difference is that things, just like active medications, one medication can be effective and the other not. Say, what's the effectiveness of this medication? What's the effectiveness of this particular procedure? Depends on your beliefs about that particular procedure and your prior experience with that procedure.
So when you say that somebody is hypnotizable, are they hypnotizable for a specific hypnotic operator, for a specific procedure, for a specific cause, or are they hypnotizable in general for any kind of hypnotic dynamic?
Okay. Usually we measure hypnotizability or hypnotic suggestibility. I think the second term, hypnotic suggestibility, is a more accurate term for it, because when you assess it, what you're assessing are people's responses to a bunch of different suggestions. And the suggestions are very different from each other. Your response to one suggestion can predict your response to another suggestion. So there does seem to be a rather broad trait of being able to expect and to be responsive to that particular kind of suggestion that we give in hypnosis, which usually involves suggesting that somebody experienced something that they know is not real. So you might be told, look, your arm is getting lighter. It's getting lighter and lighter, as if it's being pulled up by a balloon.
Helium balloon.
Yeah, by helium a balloon. And
now, when something like that happens, does it mean that the person is particularly suggestible to that suggestion?
yeah, and the answer to that is no. So the person who is more likely to feel their arm getting lighter is also likely to feel their arm getting heavier if you suggest that, and to have other, these hypnotics, unlike placebo responsiveness, these measures of response to suggestion for particular suggestions, hypnotic suggestions, tend to be highly correlated.
So, for example, we know, and you mentioned it briefly, that some people have a tendency to be more predisposed to, let's say, false memories, interrogative suggestibility. Okay, so they would be more open to accepting particular ideas about their childhood, about something that happened to them, and so on. We also know from the work of Beth Loftus and others that eyewitness testimony is not very reliable, and that you can include or suggest all kinds of things that were happening just by using particular words or particular verbs,
Yes.
or even creating some kind of a picture that suggests that there was some broken glass and a smash and a hit and all kinds of things like that, contact when no contact was there, and so on. This is why it's becoming very important for me how you sometimes insist on using very specific terminology. For example, the difference between hypnotizability that a lot of people like to use and the difference with hypnotic suggestibility. And I like these nuances because you're actually sending a message with that. And your message is, these are forms of suggestibility. So suggestibility comes in many forms, and this is one form of suggestibility. It's hypnotic suggestibility. You might also have, a different kind of suggestibility to something else. If you had to create a lexicon or a taxonomy of suggestibilities, what would they include? What would they be?
Well, hypnotic suggestibility, there's placebo suggestibility, although that, from the data, we know that's not a unitary construct at all. We already mentioned interrogative suggestibility. It has to do with the context and the nature of the suggestion in terms of how much of a trait there is of this kind of suggestibility.
But do you think there's suggestibility to spouses versus suggestibility to parents? There's suggestibility to doctors versus suggestibility to, salespeople and so on?
But again, you have to distinguish between two things. One, what is the nature of the suggestion that's being made? That's the distinction that I am making. Then there's a question within that, what do we know about the person making the suggestion? So someone who's more believable is likely to have a better effect. Someone who has the credentials and the person knows that this is a doctor, not just a lay person, and the thing that the person is suggesting has to do with medicine, is going to believe that more and likely to be more suggestible to that.
Yeah, yeah. So when you are looking at a suggestibility as a construct, do you think that it has an evolutionary advantage? I mean, do you think that it serves us well, humans, to be suggestible? What is the advantage of being suggestible, or the disadvantage?
I'm going to go to two parts of that. One is there's an advantage to being able to anticipate what's going to happen. And I think that's the mechanism with which suggestions have their effect. I'm sorry, I've got to.
That's okay.
Start that
We're gonna edit. We're gonna edit it. Don't worry about it. So this is about the advantages of being suggestible.
Right. So yes. So your experience, the experience that you have at any moment in time, is a function of two things. It's what's happening out there, or inside your body, your feet, your legs, and what's happening up here in your head. And that's true of any experience you have. It's a confluence, and there's a reason for that. That has developed because of an evolutionary advantage. If I'm walking in the woods and I see something in the path, and it could be just a branch that's fallen from a tree, or it could be a poisonous snake. Now, if I know that there are poisonous snakes in this area, I'm much more likely to resolve those two possibilities by seeing it as a snake. It's the same thing. I could see it this way till I come close enough to examine it, but if it's something that's dangerous, you don't want to have to wait to come close and get bitten and get
right. Better safe than sorry.
Exactly. So that's the evolutionary benefit of expectancy. What a suggestion does is it helps to shape and alter your expectations. So if I say to you, oh, in this area of the woods, there aren't any snakes. It might be true, it may not be true, but if I believe that there aren't any snakes in this area of the wood, I'm not going to be anticipating seeing a snake. I'm more likely to see the piece of branch of wood as a branch of wood. That can have beneficial effects. It can have negative effects. If the suggestion tells me, the suggestion is that there are no snakes here, and in fact there are poisonous snakes here, it's going to have a disadvantage. If there aren't poisonous snakes there, it's going to have advantage because I'm going to walk faster, I'm going to be less worried about what I'm going to see. So advantage, disadvantage, it depends.
So in general, you think that the evolutionary advantage of being suggestible is the ability to some extent predict the future, predict what's about to happen, look into the future and prepare with your expectancies as to what is going to transpire. That's basically the idea.
That's the advantage and the disadvantage, depending on the nature of the suggestion, whether it's an adaptive suggestion or a maladaptive suggestion.
Now, a few decades ago, a number of people started this idea that they wanted to change people's suggestibility. They had, a whole undertaking of trying to teach people how to become more suggestible. And it came under a lot of fire because it wasn't entirely clear that they were not doing something that at a metacognitive level, they were not really doing anything. They were just cheating themselves. Is it possible to change suggestibility now that we know that the psychometrics of suggestibility are very stable? Test, retest reliability, validity show us that these are more stable than IQ scores. They stay stable over the years. What does it even mean if we want to change our suggestibility? Is it an innate trait that we're born with, like a fingerprint or something like that? Or is it something that, we can, by thinking about it, by doing exercises, by going through some kind of a workshop, we can become more suggestible?
Okay. The answer to that is, first of all, we have to clarify that we're talking about hypnotic suggestibility.
Absolutely.
Not other forms of suggestibility. Hypnotic suggestibility can be changed. There are a number of ways of doing it. Some of them have been criticized but others not. So there were studies showing that if you put someone in a flotation tank that restricts their
sensory deprivation,
sensory deprivation box, that can increase hypnotic suggestibility.
I like that slip. You said sensory desperation. I said sensory deprivation. I like that. I like that.
Let's say sensory deprivation. So that can do it. There's a study that we have done twice that was first actually done by a graduate student of Ted Barber's, who was doing a doctoral dissertation. So we were the two last replications of it, in which we were able to alter hypnotic suggestibility by giving people who had never experienced hypnosis an experience in which we cheated. So
this is the famous red light study.
That's the one. That's the one. So the person is in a room. They undergo a hypnotic induction. They're asked to remain deeply hypnotized, to open their eyes, and they're told the room is beginning to turn red. You can see it beginning to turn red. And someone in the next room is gradually turning up a red light bulb.
Unbeknownst to them, of course.
Unbeknownst to them. And they actually begin to see it turning red. And then they say, okay, now it's turning back to normal. It's beginning to turn green. Okay, now it's turning back to normal. You're beginning to hear some soft, faint music in the background, and you play very faintly some music. And then you tell them to close their eyes again. And now they had the experience of successfully experiencing what you've suggested with some fairly difficult suggestions, but you've done something to generate the experience, and they don't know that. Now when you give them suggestions to measure their suggestibility, their hypnotic suggestibility, what happens, if you don't do that, about a quarter of the people are low hypnotizable. When you do that, no one's a low hypnotizable. People are either moderate, or the majority of them become high hypnotizables because they've had that experience that changes their beliefs about their own ability to respond to these suggestions.
We were talking about the red light experiment and how a tiny bit of clandestine, injection of red light can change how the entire situation is perceived by the subject, by the participant, and as a result can change suggestibility, in this case hypnotic suggestibility. Do you think that we can also change other forms of suggestibility in similar ways? Not hypnotic suggestibility, but suggestibility to placebo, suggestibility to maybe pain, and so on.
I think we can do that for example, particular placebo treatment. So if I give you a placebo pain medication and I do something to convince you that this works, one way of doing that we've done in a number of studies is using experimental pain stimulation and surreptitiously decreasing the level of stimulation so that the person has the experience of experiencing less pain. That's conceptually the same as the red light study. You can think of it as a conditioning procedure. It leads people to believe, oh, this medication really works. I can feel it working. And that may be complete placebo, but that does make people more responsive to that particular placebo.
Yeah, I mean,
not the placebos in general.
Fabrizio Benedetti does similar things with athletes where he, tells them that something weighs a particular, I don't know, 100 kilograms, and
Yep.
you lift it, and unbeknownst to them, he takes off a little bit, and he tells them, you see, now you're stronger, and he gives them a shake to drink or something, and
Yep.
they attribute it to the shake. So then on the
Yes.
day of the competition, he can actually give them the shake, and they're a little bit stronger. This is a kind of almost like psychological doping, right? I mean, if we were, let's say, I don't know, sitting on the Olympic committee or the ethics committee, they will say, absolutely no doping. You cannot take any illegal substances, and you cannot, make yourself run faster or something. Is this not a form of psychological doping where we're sort of creating or playing with their mind in order to make them stronger? I personally don't feel like that, but I mean,
Yeah.
some people do.
Well, you can think of it that way, but it's so common. Isn't that what coaches do with athletes, with their team? It's nothing considered wrong about building up a person's confidence in their ability to do something. That's different than giving them an artificial substance that's going to change their behavior, their tolerance, their pain level, and so on.
Mm-hmm. Is, in your opinion, and again, it's an ethical question, and I'm not sure that there is a right answer or a wrong answer, but if I gave somebody some kind of an enhancing substance that was a small red pill, and it came in the form of a small red pill, and when they were exercising, when they were preparing for the Olympics or for the big competition, every time I will give them a small red pill so that they can go and perform better. And then on the day of the Olympics or leading to the Olympics, I would switch that for a placebo, and I would give it to them so that it would create the same effect. And again, I'm counting on conditioning and on expectation to kick in. Do you think that that's legitimate? Because now I'm not doping them, and when they come to the Olympics, they're going to pass the urine test. They're going to there's no illegal substances in their body, but I am basically, I guess, playing on the platform that I've created before.
So there are two different issues involved here. One issue is whether you should consider that cheating somehow. And since you haven't administered anything at the time, I guess you're not cheating. Depends what the rules are. And I don't know that there are any rules that would consider that cheating. On the other hand, it does entail deception, and that's a problem. So what we did with the people with the green, blue, red lights and the flickering lights and all of that, we had about 6 different suggestions that we were reinforcing that way. That was deceptive. We couldn't just transfer that to the clinic, for example. That would be the problem. You can use deception in a study if the study is the only way to answer the question, and if you're not doing any harm, and if you debrief right after the study. Of course, in practice, if you debrief and you told the person, oh, what we did was we gave you a placebo pill instead of the real drug at the time of the race, and that's why it was okay to do that, because we didn't put any substance.
Right.
But then what you're going to do is you're going to lead the person to start mistrusting the trainer, the coach, the administrator of the
right,
pills.
and that's the biggest fear that physicians have, that if they start giving placebos and they start using, I'm not talking about open label placebos, I'm talking about placebos
Right.
where they use deception.
Sure.
That they're not just gonna lose the patient, they're gonna the whole profession is gonna suffer, because the reputation of physicians is gonna go down the drain, and that's a point that we need to heed. The other question, of course, here is, do you think that there's a place for deception other than these guidelines that you mentioned before of the American Psychological Association? Can you see situations where using deception clinically or even for research purposes is justified, and it doesn't go just by these guidelines? I'll give you an example. is it okay, for example, for me to use deception through magic tricks in order to establish better rapport? So I don't declare it as a magic trick. I just say something like, Irving, I'm going to ask you to think of a number, and I'm going to think of a number, and I'm going to write it down here, and I'm going to put it face down in front of you. And if we happen to think of the same number, that means that we are tremendously synchronized, and we're going to have a great session. I'll be able to help you a lot more than if the numbers are not the same. By the way, what was your number? 336. Turn it over, and when you do, it's 336. And now I've created, through this magic trick, which is well established in the magical literature, now I have established a special connection with you, because you don't know that this was a magic trick. And to you, this is a tremendous feat of, or a tremendous demonstration that we have a very good chemical rapport here, and that I can really, if before you thought that I could help you, now you're convinced that I can help you, because the proof is in the pudding. It's in the 336 on that piece of paper. And now we can start a session that might be of a placebo nature, but all the infrastructure is already there. That's a form of deception, but maybe it's a form of deception that should be allowed under certain conditions. I don't know. How do you think about that?
Yeah, I think it certainly would work. It would be an interesting thing to demonstrate in research. Clinically, I do think it's problematic. And I think it's problematic precisely because of the deception involved. It can lead to lack of trust on the person's part, especially if they wind up seeing through the deception, which, especially if someone finding out that you're a magician.
Well, there would need to be disclosure at some point.
Yes, and when you do disclose, what's the effect of that on your patient? What is the effect of that on your client trusting you in the future? And that might be an important.
Yeah, some clinics that I know are now using forms that patients are filling out, where they give the clinician, the practitioner, permission to deceive them if they deem it necessary or helpful for the therapeutic operation. So they do this a priori in some kind of in advance, overarching blanket kind of, I give you permission to do, as a clinician, I give you permission to do this if you feel that this is going to be helpful to our therapeutic encounter. Does that sound to you like it makes it ethical?
It depends on how it's done. And one thing that I know from informed consent forms and being a patient, so I'm sure this has happened to you too. You're going in for some kind of procedure and so on. You're given this long form, 4 pages long, and they turn it right to the signature page and sign it, and you don't have a chance to read it.
Or process it even.
Yes, or even you need to read it before you can even process it,
yeah.
And you can't even read it, let alone process it. So you don't know what it is that you've signed. That in itself is an ethical problem, I think, that we
Yeah.
do informed consent to meet the letter of the regulation, but not in a way that's really informed consent. Now then the question becomes, if you get informed consent that's very clear to the person, how is the person going to react? We don't know. What is that going to do? Now you've gotten past the ethical barrier because you've told them, I may lie to you in the future if that's okay with you, and I think it's in your best interest. What's the effect of even suggesting that to them on their clinical relationship with you,
Yeah.
on their response to your intervention? That we don't know. So there's 2 issues. One, there's the ethics, and then there's what are some of the longer term practical effects. And that's worth studying, worth looking at.
Yeah.
There's another very similar thing, which is you can sign forms saying that it's okay to not disclose side effects to you. And again, is that ethical? Well, it meets the stricture of you're not being deceptive now because you've asked for their permission to not disclose
Yeah.
it. Is that a good idea? I don't know.
Yeah, and we all know that ethics is a moving target, because what's ethical today is not necessarily ethical tomorrow, and certainly what was ethical last week is not ethical today, because
Yes.
these things, change, and they're a function of politics, they're a function of lawsuits, they're functions of many things. Can you envision a situation that placebos would be given openly and people will be able to purchase them and get them in pharmacies and so on? I mean, can you see a situation?
That's already done. You can buy them on, I won't even mention the name of it. Think of the most widespread mail order thing that you can do online, and it has a product called Zebos, which are in fact placebos. And it says in the advertisement, in the explanation of what it is, that it has no active ingredient. It's a placebo, and you can buy your placebo pills online and get it mailed.
Yeah, and of course, as you know very well, I lived for many years in Canada, and we would go to the pharmacy and get our placebos right there. To the point that I would, do my placebo studies with the stuff that I would pick up, that day from the pharmacy. I would just go and get it.
Now, I'm trying to remember from a visit to your lab some years ago, and didn't you once run into some problem with a pharmacy being able to do that?
So what the problem was that they actually charged the insurance for it. Okay, so basically what I ordered placebos, they gave me placebos, but they charged the insurance for it, and the insurance was, up in arms about, how can we, why are we reimbursing for nothing, basically. So it was an interesting, funny, bureaucratic game, but there was no problem with getting the placebos.
Okay, so now the question is, in Canada, you have national health, and I assume that was what was covering
Yes.
prescriptions. In here, it's even more difficult because we don't have national health, and if you disclose it to the insurance company, they certainly will not.
Yeah, and that's sort of a completely different layer. It's a completely different layer of discussion. How is health administration, and how is the health? I would say the infrastructure, the system. Certainly, we don't have socialized health in the United States. How does that impact the ability to do, clinical use of placebos as part of our clinical armamentarium? And do you think that some countries, for example, in Europe or places where socialized medicine is more popular, are they likely to be more open to it? We already know, for example, that in places like Switzerland and Germany and so on, there's a growing number of people who are doing alternative medicine. They're doing acupuncture, they're doing homeopathy that we mentioned before, by certified physician, by MDs who are went to medical schools and so on. In the United States, it's almost unheard of. People would be afraid that they're going to get delicensed, or because they consider it to be bad form or whatever. And placebos fall into this category.
On the other hand, there have been studies of the degree to which physicians in various countries acknowledge that they give placebos to their patients at times, and it's a very high percentage. And that's been studied in Israel, and it's been studied in the UK, and it's been studied in the US, and it's been studied in Canada.
Absolutely.
And it seems to be as prevalent in the US, where we don't have a national health system, as it is in countries that do.
The only difference is that in countries that have socialized medicine, the physicians are not afraid of giving placebos straight up. In places like the United States, instead of giving a placebo, physicians would prefer to give a subtherapeutic dose, or they'll prefer to give a vitamin, or something that would still count. So for example, they'll give a tiny, tiny dose of a particular drug that they know as clinicians is not going to do anything because it's too low a dose to be meaningful. So to them, in their mind, that's a placebo. But to the patient, that's a meaningful, So all these gray zones, all these game playing. There's really very little research done there. Like, we don't know.
Well, in the survey studies on use, of placebos, my recollection is that they also ask whether they use pure or impure placebos.
Right.
A pure placebo being just a pill with no active ingredient of any kind, and the impure placebo being the other thing you talked about, where you're giving something that is an active drug but is known not to have any effect for the condition you're trying to treat. Most physicians, there are more physicians in every country, I think in the US as well, and in the UK as well, and are likely to use impure placebos.
That would be the preference of most physicians.
Yes.
Yeah. The other, I mean, the other interesting part here in this discussion is this entire notion of what do you do with vulnerable populations. So, for example, we know that with children, parents use placebos all the time.
All the time, yes.
I'm going to
kiss the boo-boo.
I'm going to kiss the boo-boo. I'm going to give you a rub. I'm
Right.
going to give you. I have a special magic ointment. I have this. I have that. It wouldn't occur to most. I think most people would feel very comfortable with these kind of things. But you do that to an adult, and you're in trouble because who do you take me for? Do I look to you like the question is, usually our thinking is the opposite. Usually we are far more careful with children and with vulnerable populations, if it's prisoners, if it's, other, because they don't have many choices and because they're not independent and so on. Here's a situation where the dynamic seems to be reversed. We are allowing ourselves more latitude over there. Should we?
I really don't know. That's an excellent question. I haven't thought about that, and it's something that I wouldn't want to respond to just off the top like that. I would want to give some more thought to that.
Yeah. So the other element of what I'm trying to promote here, and you're the perfect person to have this discussion with. You've been doing hypnosis. You've been doing antidepressants. I'm talking about work and research for many years.
Yeah.
You know the literature really well, and you've met the people in person, and these are two worlds that are almost like silos. In other words, people from the antidepressant field are mostly psychiatrists or clinical trialists, and they're people who are doing it. They're not necessarily the same people that you meet when you go to hypnosis conferences and so on. How did you manage to sort of balance these two careers at the same time, side by side, with antidepressants actually taking over more recently? And how did that work? Is there crosstalk there? Is there something interesting happening there? Can you talk to us a little bit about that?
There's one thing that unites all of my research, and that is this interest in the role of people's beliefs and expectations, and what I call their response expectancies, what they think is going to happen automatically to them, on their behavior and their experience. And one way of doing that is through the use of hypnotic suggestion, with or without the induction of hypnosis, and in others giving a placebo pill or some other sham treatment. And there are many other ways of doing it, all the different forms of suggestibility that we've mentioned and talked about.
So do you think that, for example, your research on hypnotizability, hypnotic suggestibility, inductions, the ability of people to follow suggestions, to form expectations, did that inform some of the thinking, some of the ideas that you had when you started looking into antidepressants? Was it something that was on your mind, or were you mostly interested in, trying to help people with psychotherapeutic interventions?
When I started looking at antidepressants, I wasn't interested in either of those. I was interested in the placebo effect. Is there a placebo effect in the treatment of depression? How large is it? I believe that there ought to be. That's that question of a person's belief and their expectations. That's the center of all the studies. I got interested in placebo effects before getting into hypnosis at all, and I became, first of all, interested in hypnosis because I was trained in it as a graduate student in a clinical program.
Right.
So I used it clinically. But then when I started doing research and I got my first academic job, I said, well, I bet that's also has to do with a person's beliefs and expectations. So there's another area in which I could study that, and began studying that with my graduate students.
So what would you say your biggest achievement research-wise is with antidepressants? What would you say your biggest achievement or your biggest influence is on the field of suggestibility?
I can't answer that. The biggest influence, I leave that to you and others who have read my work to say, oh, this has been really influential.
So I can answer that very easily.
Yeah.
I can tell you that for me, as somebody who's been following you for many, many years, including even before I met you, and as you know, I came to you specifically about hypnosis and suggestibility,
yes,
not about the antidepressant thing, and that's, you know, that was a later kind of add-on for me. But for me, the ideas that you put forward, connecting the whole notion of hypnosis to social psychology through trying to again, together with people like Spanos, together with, to me, that was revolutionary. I mean, I found that to be very revealing, because before that, based on my training and so on, my entire conceptualization of hypnosis was going in the direction of there must be a deterministic neural, you know, mechanism here that I need to look at. And I was able to entertain both worlds to, you know, to a large extent, and that was very meaningful to me. In the antidepressant thing, it's a very different contribution, the contribution there, and that also has to do with the fact that I was entrenched in psychiatry departments my entire adult life until I moved to Chapman recently. It was fascinating for me to see how your work shows the antithetical, you know, I would say message to everything that was surrounding me in the psychiatry department. So all the grand round lectures, all the seminars, all the workshops, all the papers, all the, you know, hallway discussions were all about how great antidepressants are, and how, you know, we should you know, elevate the dose and do this and do that and do that, and how other people don't understand, and, you know, they're blowing it out of proportion. And all the work that you would send me and that we would, you know, used to talk about was showing how these things are actually not half as effective as they're claimed to be. And it was striking for me to see how these two worlds can coexist, how, you know, people can choose not to look at, you know, these data at all. And I'm still struck by that to this day, and it's been more than 20 years.
Yeah.
So it always brings me to the same question: when do you think it's going to happen? And, you know, I like it when you tell me about, you know, Kuhn and the structure of you know, of the scientific revolution and all, but maybe you can share that, you know, with some of our viewers.
Sure. So there was a philosopher of science who was the most influential philosopher of science in the 20th century. His name is Thomas Kuhn, and he wrote a book called The Structure of Scientific Revolutions, and he talked about how people get wedded to particular ways of seeing the world in which they work. And he calls that a paradigm that they have, and how paradigms shift over time. But he says what happens, the way in which they shift, the way in which you have scientific revolutions, it's not that you convert everybody who used to believe that gravity was an actual force to Einstein's conception, that it's not really a force, it's just an expression of the curvature of space and time.
Mm-hmm.
The people who have grown up in the old paradigm are wedded to it. They've got their whole careers attached to it. It's very hard to change their minds, even with the best of data, and that's normal. That's normal human functioning. But if you have someone that's younger in the field, that it's newer to it, they're not as wed to the old conception, to the old theory. They don't have, it's not something that they've believed in for 20 years. And they are more easily influenced by the new data. So because of that, scientific revolutions take time, because what happens is that the old timers die out, and that's when you have the paradigm shift. As the old timers die out, there are more and more young people coming into the field. they are not wedded to the old beliefs, so they are more adaptive and more responsive to the new data that are coming out.
So, based on Thomas Kuhn, you think we just have to sit and wait it out for all these antidepressant fans and advocates to basically leave the scene, maybe naturally, let them expire before we have a revolution or a change that appreciates that there are other ways to treat depression and anxiety, not through antidepressants but through other means?
Well, I don't think we have to just sit and wait. I think we have to continue to generate data, to publish the data, so that new people coming into the field who are medical students, recent graduates, can be influenced by it, and that can change. But yes, it does take time. There is a surgical procedure that's called arthroscopy that is done for degenerative knee disease. And back in 2002, a study was done comparing it to a sham surgery, in which in the sham surgery group, they opened up the knee. They didn't do the surgical procedure. They closed the knee back up again. So that was the sham surgery. People thought, they were told they might be getting the real surgery,
right.
They might be getting the sham surgery. The sham surgery did as well as the real surgery. And in fact, for the first year or two on a couple of measures like walking, climbing stairs, for the first year, I mean, it actually did better than the real surgery. After 2 years, there was no difference between the two. You'd think they'd stop doing that surgical procedure. British Medical Journal, just a few years ago, wrote a clinical guideline. They noted this study, the replications of it, showing that there's no surgical benefit from this, and at the same time, their data that physicians were not only using it, that procedure, that surgical procedure, but the rate of use has increased in every country that they could find data on since the studies demonstrating that it doesn't work.
That's just sheer craziness.
It's just, it takes, so they issued a clinical guideline that it should basically be used with no one.
Yeah, even with those guidelines and even with, all these things, this is just sheer madness. I mean,
It'll take time, but that's normal stuff. They use bloodletting for years and years and years and centuries. And when people start discovering that it's not working, it took a while for people to stop using that.
Irving, it's such a pleasure to have you here, and I want you to know, as you already know, but I want everybody to know, what a tremendous mentor you are, who not only influenced my professional career and my thinking and how to design experiments, how to think about science and clinical science, how to think about statistical significance versus clinical significance, so on and so forth, but doing it with such grace and poise. And I've learned from you not just to think in a dispassionate fashion, which I can't always implement as well as you do. I'm just a little bit more animated, I think, when it comes to certain things. But one of the things that you taught me very, very well is exactly what you said now, that data are not enough. It's not enough to just, because I was always under the impression that if I just do the right study and I would put the data on the table, everybody would look and say, now we understand. We got it wrong before, but now you showed us that it's right, and now we're going to correct it. And there are examples in the history of medicine where that happened. It happened very quickly, but apparently not here. And part of the reason I think that this is not happening here is because we're dealing with market forces. We're dealing with industries that are able to get tremendous revenues and benefits and make, frankly, a lot of money out of this. And the second money is involved, and politics is involved, and policymakers and regulation and so on, it ceases to be a scientific matter. It's no longer about the science. So I salute you for being as close as possible, as close as you can be to a pristine scientist, and keeping yourself away from all this market force madness. And I really hope that at some point the voice of reason and your excellent work, your transformative work, people would heed what the consequences are, because I think that it's going to help millions and millions of people, particularly in a society, certainly in the United States, where more than 10% of the people are on antidepressants, specifically for depression and anxiety, as we both know. Not to mention the fact that we're dealing with a pandemic situation that is likely going to even accelerate and exacerbate the situation even more. Thank you so much for coming here. I am so thrilled, not just to have you here, but to have basked in your light and to be under your wing for so many years. And I hope that you are going to come here again.
Thank you, Amir. And I've got to say something too, because I also get very passionate about things, and I get convinced by the data, but then I get very passionate about it. So I understand that's something we have in common. We have another thing in common that I noticed from our very beginning of working together. You came up to UConn, where I was teaching at the time. You were planning this study with hypnosis and the Stroop effect. We talked about it. I told you, I don't think you'll get the result that you did when you did the study. You took some advice from me on methodology. You did the study. You got the result that you predicted. I was wrong. You got it. Wonderful. And then I said to you, you should try that without the induction. I bet you don't need to induce hypnosis to get that same result. You didn't believe it, but you did it with me.
That's right.
And we found out, I was right about that part, and you accepted the data. So one thing we have in common is we both look at the data that's different, that's what we predicted.
Right.
And I think that's one of the reasons that we have worked so well together as a team, my colleague and brother.
Thank you.